Good evening and warm welcome to all the delegates and the panel speakers that have joined online for this very interesting session, which is this session three of Grand Rounds in Rheumatology. And this is basically an IRA eConnect program where Indian Rheumatology Association and ABBOT have a joint collaboration. The topic today, in the past, we had discussed two topics. One is axial spondyloarthritis, and the other is rheumatoid arthritis. And today also we have a very interesting topic, which is psoriatic arthritis, which is evolving in nature and difficult to treat at times. Just a thing that I want to mention is I urge every participants to note down their questions and put it in the chat box during and after the during the panel discussion to mention in the chat box. So moving forward, I would like to extend my gratitude to the team IRE Connect, who has worked extensively on this program and helped the Indian rheumatologists for the scientific accreditation. To introduce the first expert, we have Professor Philip Mease. He is working as the Director of Rheumatology Research at Swedish Medical Center, and he himself is the founder of GRAPPA, um, uh, which is extensively followed by globally for the management of psoriasis and psoriatic arthritis. He is also the past president and executive member currently for GRAPPA. He is also the scientific director for multiple registries, including Corvitas, and part of multiple working groups, OMERACT and SAPO. As an authority, he is on the editorial board of NEJM, Lancet, Journal of Rheumatology, to name a few, and also peer review for multiple PubMed index journal. He has also received the Lifetime Achievement Award for his contribution to the field of psoriatic arthritis by National Psoriasis Foundation in the year 2019. Just to highlight his contribution to the field of rheumatology, he has contributed 6 books, 20 book chapters, and more than 700 publications on psoriatic arthritis and other autoimmune diseases. We welcome you, sir. To We have the Indian expert. We have Dr. Ashish Mathew, who is the professor at CMC Vellore. Sir is keenly interested in psoriatic arthritis and axial spondyloarthritis in India, and has worked on multiple trials. To highlight a few, he has worked on COPCOD India initiative. He is also the member of GRAPPA and Indian Rheumatology Association. He is also the co-convener for EPLAR's Special Interest Group for COPCOD, as well as the executive member for EPLAR COPCOD subcommittee. As an associate editor, he is empaneled on the Frontiers in Medicine Rheumatology and also the peer reviewer for more than 10 journals. To his credit, he has more than 100 publications and 9 book chapters. We welcome you, sir. Today's facilitator moderator is Dr. Mohit Goyal, who works as a senior rheumatologist at Udaipur. He is working keenly on psoriatic arthritis and axial spondyloarthritis, and he's a steering committee member for the PASIC India, and as well as the member of EPLAR and Psoriatic Arthritis Special Interest Group Registry, where he presented his interim data in the recent IRACON at Bangalore. He is also the executive member, Indian Rheumatology Association, as well as the honorary secretary for Society for Pain and Arthritis. Also, he serves as an associate editor for Indian Journal of Rheumatology, as well as the Journal of Royal College of Physicians of Edinburgh. He is a keynote speaker, as well as he is keenly interested in writing, scientific writing, and to his credit, he has more than 100 publications as well as 10 book chapters. We welcome you, sir. Just quickly, for the benefit of the audience, I would like to highlight the program agenda for tonight. We have a welcome address by the IRA President, Dr. Chandrasekhara. Then we have the context setting by Dr. Mohit Goyal, and then we move to a 1 hour presentation, which is 30 minutes by Dr. Mease on the recent advances for psoriatic arthritis, and then by the Indian challenges in managing psoriatic arthritis by Dr. Ashish Mathew. And then where we have the questions ready, we would have 15 minutes of panel discussion, followed by a quick vote of thanks. So with this premise in mind, I would like to hand over to Dr. Chandrasekhara for his address.
Good evening. It's one of the ongoing program which has really got a lot of attention from both from Indian Rheumatology Association members as well as the other across the specialty. I think this is a program which we really conceived when the personal meeting was not possible during the COVID time. And it has really made us to understand that this platform is one of the real platform which can help us to connect to large number than what we would have otherwise if we do a face-to-face program. I think this is our 6th or 7th in the series and 4th one in this particular year. And today, I think we have eminent speakers more towards on the psoriasis, Professor Mease and Dr. Ashish. I welcome both of you for today's eConnect program. And I think I welcome all the delegates who have been logged in. I think without taking much time in between the speakers and the delegates, I hand over to Dr. Mohit. Mohit to start off.
Thank you, Dr. Chandrasekhar. So this IRA eConnect program, this has been rekindled by our President, Dr. Chandrasekhar, and Secretary, Dr. Vinod Ravindran. We have had 6 webinars this year. We started the year with the best abstracts from the last IRACon that was held at Hyderabad. Then we have had Professor Ernest Choi, Professor Nijil Haroon, Professor Gerd Burmester, Dr. Natasha Jordan, and today we have Professor Philip Mease for this meeting. So why PSA? So basically PSA, as we all know, that it has multiple domains. Many a times we are struck with patients where we think that they are largely doing well. But say one of the domain, there is a difficult to treat enthesitis or a difficult to treat dactylitis. Overall, the patient seems to be doing well, but one of the domains is not responding. Then another issue that we face with PSA is the axial part of it, axial psoriatic arthritis, which remains not that well defined as of now. We were there discussing at this IRACon also, how do we exactly define and characterize axial psoriatic arthritis? It remains under-recognized and suboptimally treated. Then, as we all know, that the comorbidity burden in psoriatic arthritis is pretty high. And in particular, in our Indian setting, where we have a busy clinic, these comorbidities are not sufficiently looked for in our clinics. Then there are certain elements like depression and fatigue, which are we call the difficult to assess or difficult to gauge, or the metrics don't help us much with these two domains. And they are pretty important aspects of patient global or patient well-being in psoriatic arthritis. Then another aspect that we don't often discuss about because of the cost constraints and the resultant lack of experience is the combining two targeted therapies. So all these topics will be touched upon today in our session. So without taking much time, this is the background, and I'd like to welcome our first speaker, Professor Philip Mease, for his deliberation.
Thank you very much, Mohit. Allow me to share my screen. Please affirm if you can see this okay.
Yes, this looks okay.
Okay, good. So thank you very much. What I'll be doing today is touching down on how I go about identifying and assessing the different clinical domains of psoriatic arthritis. And then I'm going to touch on some of the newer data sets that have to do with what we do with patients who have we find to be difficult to treat. And I'll get into that more in a moment. These are my disclosures. I like to start with this slide because of the way in which it captures very well the complexity of psoriatic arthritis that Professor Goyal was just referring to. And I'm going to speak to each of these, but here we have patients with evidence of psoriasis, nail disease, arthritis, enthesitis, and that middle picture which shows enthesophytes, at the Achilles tendon and plantar fascia insertions, dactylitis, which represents arthritis, enthesitis, tendinitis, and osteitis all in one digit, and is pathognomonic for psoriatic arthritis. We also have evidence of spine disease in the imaging that we see here, and the associated conditions that are genetically clustered, which include inflammatory bowel disease, uveitis, and then the unfortunate issue of metabolic syndrome, which is characterized by obesity, hypertension, hyperlipidemia, and Ashish will be going into that in much more detail. And here we have again photographs of the key domains that we want to ask about each time we're in with a patient in the clinic. Do they have active arthritis or not? Do they have active enthesitis? Enthesitis is often poorly characterized and hidden, and patients may not realize that, for example, the chest pain that they're experiencing from the insertion sites for rib cage ligaments, it represents psoriatic arthritis flare, and so on. And axial disease, Ashish will be getting into much more in detail. Here is a cartoon from Chris Richland's New England Journal article from 2017, wonderful review of psoriatic arthritis, and gets across the point that depending upon the domain that is active, there will be overlapping cells and cytokines that are part of the inflammatory process, but there are also distinctions. And this is why with some of our therapies, we may do very well, say, in arthritis or skin manifestations, but when it comes to the spine, for example, or the gut, that may lag behind. I'm going to show this once and then again later on, but the GRAPPA group recognizes the complexity of the different domains. And whenever, each time that we come up with new treatment recommendations, we have groups of experts in each of these domains cull the literature to determine if there is any new evidence for efficacy in that particular domain. In general, you see that most of the treatments that we typically use that are conventional synthetic DMARDs, biologic DMARDs, or targeted synthetic DMARDs, the newer JAK inhibitors or PDE4 inhibitors, are all effective in domains such as peripheral arthritis, enthesitis, dactylitis. But when it comes to the spine, we don't have the strong evidence for each of these to be effective. Let's look at peripheral joints. This is a patient who has psoriatic arthritis. How can we tell? Well, there's subtle evidence of nail disease. It's a male instead of the predominant female that we see in rheumatoid arthritis. And we see evidence of distal interphalangeal joint involvement, especially the fourth finger, and also evidence of dactylitis, the second digit, and possibly the third. Here is an examiner examining a joint, and notice two things. Notice the whitening of the nail in the examiner's thumb. If you whiten the nail about a fifth of the way down from the tip, that's about 4 kilograms per centimeter squared of pressure, and a standardized amount of pressure that we apply to assess for tenderness or swelling. The other technique that's shown here is what I call 4-point technique, where the circumferentially around the joint line, there are 4 fingers assessing for swelling. Typically, in clinical trials for psoriatic arthritis, we recommend 68 joints to be assessed for tenderness and 66 for swelling, excluding the hips. This is different than rheumatoid arthritis, and one of the reasons that we ask for the ankles and feet to be examined carefully is that oftentimes inflammation can be hidden in these joints, but not in the upper extremity joints. Here is evidence of psoriatic arthritis change, and we get two different types of change. One is bone formation or proliferation in the upper image, which is the phenomenon called periostitis. And then in the lower image, we see significant osteolysis. So proliferative bony changes on the one hand, lytic changes on the other. And then this is the classic pencil and cup change. Moving to enthesitis. Enthesitis is wherever a ligament or tendon inserts into bone, anywhere in the body. Here is on the left-hand side are shown enthesial insertions around a joint. So the joint capsule fibers, for example, or the tendon inserting into bone. But on the right-hand side, a lateral MRI of the ankle, if you look to the right, you see where the Achilles tendon is inserting. This is not near a joint. So they're both periarticular, but also non-articular areas of enthesitis that can occur. Here is a cartoon depiction of the mononuclear inflammatory infiltrate. We see swelling in this person's right Achilles tendon insertion, and a biopsy from one of my patients, which shows the infiltrate. Here is a cartoon from one of Georg Schett's articles before he became really famous for CAR T-cell therapy in lupus. One of the areas that he has a abiding interest in is the phenomenon of enthesitis. And this shows the evolution from resident T lymphocytes, gamma delta T cells, ILC3 cells being activated and producing inflammatory change. Much of the cellular infiltrate that constitutes enthesitis is migrating from the marrow, so from interior to the bone, as opposed to coming in from exterior circulation. The little red dots on these skeletons represent the places where we press for the Leeds enthesitis index on the left, lateral epicondyle, medial condyle of the femur, and the Achilles tendon insertion. Very simple, 6 sites. Then in the middle is the SPARC index, which it comes from Canada, and there are more sites there. There are a total of 16 sites that are assessed for the SPARC score, including several that overlap with the Leeds enthesitis index. And on the right, we see the Maastricht index. This is more used in axial spondyloarthritis assessment, not so much in psoriatic arthritis. And here we see an ultrasound showing Doppler light up in the Achilles tendon insertion. This is one of the more verifiable ways of assessing for enthesitis, because many patients, for example, who have a degree of fibromyalgia or central sensitization may have tenderness at these when we press on these sites, yet there may not be inflammation there. I call that enthesalgia, and it's to be distinguished from true enthesitis. Here we have evidence of dactylitis, or so-called sausage digit, which is seen in 40% of our patients. And when we see this present, it's very characteristic and hopefully diagnostic of psoriatic arthritis. Here's an MRI image that depicts the inflammation that occurs not only in the joint, here in the case of the distal interphalangeal joint, but the adjacent bone and the enthesial as well as tendon insertions. This is measured by different techniques. One is just simply by looking and seeing if the digit is swollen. In clinical trials, we use this interesting little instrument on the right-hand side here to measure the circumference of the digit. And then there's a calculation that we do for the Leeds dactylitis index. And then the spine. Again, Ashish is going to get into this much more in detail, but just to say, the spine is inflamed in up to 40% of patients with psoriatic arthritis. The most recent exercise that we've done as a ASAS and GRAPPA collaboration suggested maybe that number should be slightly lower, closer to 30%. Very difficult to assess at times, requiring imaging, both X-ray as well as MRI scanning. One of the other key points that Ashish will go into is that there can be significant differences, including the way patients answer the inflammatory back pain questions. They may not endorse as many of these questions as in axial spondyloarthritis. Asymmetric involvement of the sacroiliac joints is noted here, and the chunky syndesmophytes as seen in the lower part of this lateral view of the lumbar spine. I'm going to push on because I know Ashish will cover this in greater detail. We assess this by various techniques. Here we are measuring the Schober test, the degree to which a patient can flex forward, indicating spinal mobility. The same with the cervical spine, in which we assess whether or not the patient can touch the back of their head against the wall. And then skin and nail up. And this shows you the classic psoriatic plaque with well demarcated. That's one of the characteristics that distinguishes this from, say, cutaneous lymphoma or atopic dermatitis, where the margins or edge of the plaque are not as clear. Here it's very clear, and there is erythema, induration, it's raised, and then this scale that represents flaking off keratinocytes. And then the severe nail disease that can be seen here. We use a technique such as the handprint, representing 1% of body surface area. That's for my body. The patient's handprint is 1% of their body surface area. So a simple technique is simply to assess the number of handprints of skin involvement there is that gives you the body surface area. And then there are more complicated techniques that we use in clinical trials, such as the Psoriasis Area and Severity Index, or PASI score. Somewhat complicated. You get a score for erythema thickness scaling in each part of the body, head, trunk, limbs, and then do a calculation for a more quantitative assessment. And then there is something known as the physician static global assessment of psoriasis, where you do just take a look at the overall characteristics of the lesions on the patient's body and average them out in terms of induration, erythema, and scale. Nail disease, there are various techniques that we use to assess this as well, ranging from a simple visual analog scale of severity to more complicated scores such as the NAPSI. Now I'm back to the GRAPPA treatment schema, and what I'm going to be doing during the remainder of this talk is focusing on treatment, and in particular, difficult to treat patients. Here we have the recognition that each of the drugs that are noted in each of these boxes has efficacy. We know that CSD-MARTs such as methotrexate or sulfasalazine can be effective in the arthritis. We know that TNF inhibitors, IL-12/23, IL-23, IL-17 inhibitors, CTLA-4 Ig, JAK inhibitors, and PDE4 inhibitors used as monotherapy can all be effective in treating the arthritis component. For the axial disease, biologic DMARDs are focused upon TNF inhibitors, IL-17 inhibitors, or JAK inhibitors. So we have fewer drugs that are demonstrably and we know can be effective in psoriatic spondylitis. Enthesitis, we come back to all of the drugs being capable. So I go through this briefly because you all know these medications well, but just to say the way the GRAPPA group does it is to say, we recognize that you're going to have your own individual preferences based on your knowledge of the evidence. Patients may have their own preferences. Do they get sub-Q or IV or oral medications? And there may be cost constraints which direct us in one direction or another. Nonetheless, we all know these drugs well. But what about the situation when a patient does not respond necessarily, or responds, but only for a year and a half or two, and then their response fades, and we need to move on? We've learned that moving on, say, from a TNF inhibitor to a different mechanism of action, like an IL-17 inhibitor or an IL-23 inhibitor, may be more effective than going from one TNF inhibitor to another. So those are some learnings that we get from clinical registries, for example. But I'm going to share with you one very interesting recent study known as the control trial. Laura Coates, who's now at Oxford, was the lead author on this interesting study. And I shared a senior authorship with Philip Conahan, who is from Leeds. And here's the key outcome measure that we were trying to get to in this study. We were trying to treat to target. And the target that we've chosen is what a criteria set known as the minimal disease activity criteria. This is a criteria that was developed by Laura when she was working in Leeds and working with the GRAPPA group. What she did was she came up with 40 theoretical patients and then asked us, is this patient in a satisfactory state? And if the patient had enough swollen joints or enough skin disease or enthesitis to not be satisfactory to us as treating physicians, then that created a threshold whereby we could understand what was a good outcome versus not. And so if a patient achieves 5 of these thresholds out of the 7, they're in a state of minimal disease activity. If they get all 7, then they're in a state of very low disease activity. So tender and swollen joint count less than or equal to 1, each of those would be at point. A body surface area of less than 3%, remember 3 handprints, and low levels of pain and patient global, good levels of physical function, and low levels of enthesitis. So this was the primary outcome. How was it structured? We took patients who were already on methotrexate, 15 milligrams a week, and not in a state of minimal disease activity. They were then randomized to either escalating methotrexate to 25 milligrams or to have adalimumab added to their regimen. And then at week 16, that was the primary endpoint of part 1 of the study. And what we see here is the outcome from that. We see that 41.5% of the patients who had adalimumab added were able to achieve minimal disease activity, and only 13% of the patients who escalated methotrexate. So already now we have a sense, it makes more sense to add adalimumab at this point. But what about part 2? Let's move on. So what happened at week 16 is in the patients who did respond, had an MDA, they continued on with their treatment regimen. But those that did not had their treatment intensified. In the case of those that had adalimumab added, they went to weekly adalimumab instead of every other week. So the dosing regimen was intensified. And for the methotrexate non-responders, they had adalimumab added. What was the outcome? In the adalimumab responders, they maintained response. And in the patients who escalated methotrexate, some of them were able to maintain that response, but this is only 13%, remember. This is probably the most interesting graph to me. It shows that when you intensify adalimumab to weekly, you do get a significant further response, more patients getting into MDA status. And then, of course, when the methotrexate non-responders had adalimumab added, most of them got into MDA. So we've learned some lessons here about, and this gives us some justification for being able to intensify adalimumab. And I should say that there was really no safety cost to doing so. Here we have the evidence from that, and we just don't see much in the way of serious infection or other problems. Now, one of the areas that we're getting into more in the States and possibly in India, but I appreciate there could be economic challenges for this, but that's using dual therapy approaches. And when I use the word dual, I'm referring to combining two biologics or a biologic and a TSD-MARD. We do that. We do this quite a bit in our clinic. Here we have an example of such an approach from a Spanish cohort. These were patients who had a combination of IBD and PSA or AxSpA, and for the most part, about 2/3 of them had IBD. And you can see the various dual treatment combinations in the middle column with, for example, the patients were already on ustekinumab. That's a favorite of the gastroenterologist, but they were having musculoskeletal symptoms breaking through the combined problem of IBD and spondyloarthritis. And they had TNF inhibitors then added, 17 patients in all. And then other combinations, for example, a patient with psoriatic arthritis and psoriasis who was on secukinumab and TNF inhibitor. So these would be examples of reasons for either the skin or the gut or the joints not responding as well. On the right hand, we see what happened. All of these patients were in moderate to high disease activity to begin with, and 2/3 of them were able to get into a state of low disease activity or remission. There was a cost, and in this 29 patient group, there was one serious infection, and that was a staph sepsis. So that has to be kept in mind when you're thinking about using such dual therapies. I'm showing two abstracts that were presented at the most recent ACR meeting in Washington, D.C. And this is the beginning stages of a French registry in which they're aiming to enroll over 1,000 patients with dual therapy. And so they're just reporting on some of the first patients that are in the registry, 79 patients in total. And as you can see, usually these were patients that had refractory rheumatoid spondyloarthritis or psoriatic arthritis. And about 1/3 of the patients were, 2/3 of the patients were effectively treated with these combinations or partially effective. And they included all kinds of combinations, including JAK inhibitors and TNF inhibitors. I, again, should caution that there were a total of 9 severe infections. And of these, the majority were on a TNF inhibitor and a JAK inhibitor. So that has to be taken into account when treating patients. And here's yet another study. This was a market scan from the United States, 43,000 patients. These were psoriatic arthritis patients who had either skin or joint disease flaring of the combination or the two different domains. And here we're mainly seeing a combination of either a TNF inhibitor, IL-17 inhibitor, but also with apremilast. Here is an interesting study in which a TNF inhibitor and an IL-23 inhibitor were combined to treat ulcerative colitis compared to either drug monotherapy. And one of the key messages here is that there is not only additive, but potentially synergistic improvement when you put the two drugs together. Here we're seeing the standard ways in which ulcerative colitis is measured, and then where the combo is really better. This is, though, where we get the idea about synergistic effect. If you look on the left-hand side, we see that with this RNA-seq analysis of colon biopsy tissue, that there is a significant upregulation of pro-inflammatory genes in ulcerative colitis and a downregulation of anti-inflammatory genes depicted in purple. So orange, bad, purple, good. And then at week 12, there was a repeat biopsy done. And we see that there is a movement toward normal with both monotherapies. So numerically less bad gene expression and numerically more anti-inflammatory gene expression. But look at the combination. Almost 10 times the degree of gene expression change toward normality of the tissue. So this, to me, says, what's going on here, where there is a not just additive effect of putting two drugs together, but somehow they're empowering each drug to work better. And this is just some commentary about our own experience. We've used all kinds of combinations in our practice. And the way we get this through insurance is to have, say, the dermatologist or gastroenterologist prescribe one drug, and then whilst we prescribe a different one. And that way we get it through insurance, or we sometimes give patients samples. Okay. Now the question arises, there are various initiatives going on to create a definition of difficult to treat and complex to manage. And why do we need this? Well, clinicians need it to understand and appreciate that we're seeing patients that fall into this category who've tried 3, 4, 5 different medications. They've had a response, but then they've lost the response. What do we do when we get through all the different drugs and mechanisms? So in various real-world evidence studies, anywhere from 10 to 30% of patients in these large cohorts fall into these difficult-to-treat categories. We also know that pharmaceutical company clinical trial design teams need to have some kind of definition so they can know who are they going to put into a trial. I failed to mention that after I presented the ulcerative colitis trial, there's a similar trial that's going on in psoriatic arthritis with the same combination, guselkumab and golimumab, called the Affinity trial. And that's going to be looking at whether or not the combination yields benefit for psoriatic arthritis. So in designing these kinds of trials, we need to know what population of patients to put into the trial. Regulatory agencies need to understand that these combinations need to be studied and therefore to allow these studies to go forward. And we need to educate payers that there is a true difficult to manage population that we may need to use too expensive medications for. So here is the rheumatoid arthritis, EULAR definition of difficult to treat. Patients who failed at least 2 different mechanisms of action of advanced immunomodulatory drugs beyond CSD-MARDs, and evidence of objective evidence of active disease, synovitis on exam or ultrasound, or MRI, elevation of acute phase reactants, progressive joint damage on X-ray, and so forth. Here's the GRAPPA preliminary definition, and we've decided to divide it into two. On the right-hand side is the truly difficult to treat group, the refractory group that has objective evidence of inflammation and has lost response in each of the clinical domains, or in even just one clinical domain, whilst the others are still are being treated adequately. But then we also recognize that there's a group of patients who may not have objective evidence of inflammation, but are having pain and fatigue. And this is the truly complex to manage population. And Ashish will get into this in more detail, but this includes patients with conditions like fibromyalgia, where we can't get to the target of minimal disease activity because they have fibromyalgia, causing pain and fatigue. And so the patient-reported outcomes, such as patient pain or patient global, just won't respond in the same way. Or patients who are obese. And we've learned that patients with prominent obesity will not get to a treatment target of our desire. Patients who are depressed, patients who have concomitant difficult IBD or skin disease, and so on. The list goes on. And this is a pictorial depiction of this, where we recognize that the complex to manage patient is a larger group, and the difficult to treat one, the truly refractory patient group, is a lesser group within it. So to summarize, and thank you for your patience through this winding presentation, we recognize that psoriatic arthritis is complex. As Professor Goyal mentioned at the outset, there are multiple clinical domains that may be involved. Optimal treatment needs to take into account each of these, and we've talked through how you assess these. We have a number of effective medications now, which can be used as monotherapy, but increasingly for the more difficult to treat population, we're going to be looking at combinations. So thank you, and I'll stop my slide set and turn it back over to Professor Goyal.
Thank you, Professor Mease, for this nice deliberation. I will be taking questions at the end, so you can keep putting the questions in the chat box without taking much time, and I give it to Professor Ashish Mathew for his deliberation.
Thank you. Am I audible?
Yes, you are.
Thank you. Thank you very much for this great initiative, and I'd like to congratulate the IRE team for, in fact, getting this together. It seems to be a wonderful project going forward. This is the third one in the row, and this time being psoriatic disease is even special to me, and having Phil Mease as my co-speaker, it makes things better any day. Phil and I work together in the GRAPPA steering committee education committee, and it's been a great learning experience for me over the years, and really cherish the advice and the mentorship that I've received from Philip over the years. So I'll be dealing with kind of an Indian setting. What is so special, and how do we optimize management in our patients? Can I just, I apologize for because I have some technical issues, and that's the reason why Dr. Yogesh is manning my slides at the moment. So this is the outline how I'm going to approach this whole talk. I'll just start with challenges in the Indian context. We'll move on to the conundrum of back pain. Dr. Mease did touch upon that, and I'll deal the content in a bit of a detail. We'll go into comorbidities in psoriatic disease. Pain is the main elephant in the room, so to say, in managing psoriatic arthritis or psoriatic disease, and that I'll touch upon on a few slides, and then we'll close by, complex to manage psoriatic arthritis. The D2T versus the C2M conundrum, we'll just go through it. So I just noted a few points which I thought would be interested from the Indian setting. What are the stumbling blocks we have? Burden of disease seems to be one of the major things for me, at least, because we still don't know what is the real burden. We know that it's quite high, but we don't have a number to put on that. And that's often we go back to the study from a postgraduate institute in Chandigarh way back in 2014, where it was around 9%, if I don't mess up the numbers. But it's quite low, but we know that the burden is fairly high. Now, thanks to the two studies which I'm going to quote here, one is actually the initiative by the Indian Rheumatology Association, in which they brought up all the registries of multiple rheumatic diseases, and psoriatic arthritis happened to be one of them, along with spondyloarthritis, in which they looked at the burden and the reasons for delay for early diagnosis and early treatment in patients with psoriatic arthritis, in which the prevalence was more in females. The accessibility to care was kind of varied, and it was managed by, and what is really interesting to me was more than 50% of patients were managed by people from other specialties, which included orthopedicians, general physicians. It just shows that there in fact is a long delay in the patient reaching to a rheumatologist. And the mean referral delay was around 16 to 17 or 20, close to about 20 months. So that, can we move to the next slide, please? So these are the factors which I thought would be playing a major role. The awareness of the disease or lack thereof, lack of proper assessment. Dr. Mease did mention upon what are, so when we talk about psoriatic disease or psoriatic arthritis, we just don't talk about the joints, although many times the treatment decisions are swayed by the number of joints and involvement. However, when you look at the disease, the psoriatic disease, there has to be a proper comprehensive assessment to understand the burden of the disease, and we treat the disease and not the joints or the skin separately. Late pickup from derm clinics is a major issue. There was a paper way back in 2012 in which close to about 60% of patients, 2/3 of the patients were missed out in derm clinics. So that could be one of the reasons. Alternative systems of medicine. Somehow people have faith in alternative systems of medicines. It's not that they're bad, but oftentimes what happens is most of them end up taking high doses of steroids in powder forms, and that leads on to the burden of increases the burden of the disease as well as comorbidities. Patient education is still a major role to be played by the physicians. Of course, we do have fantastic initiatives going on, but still there's a long way to go. And of course, referral inertia, which was kind of depicted in the survey, which I was referring to earlier. Next slide, please. So that brings us to the central point of the whole thing, which is actually paying capacity. So the heart of the matter is paying capacity, regardless of what the patient has, what the number of drugs we have. At the end of the day, paying capacity of the patient drives the entire thing, because very seldom people have access to insurance. And so the same goes with federal support, which is quite not up to the mark in India. So at the end of the day, whatever we talk about, at the end of the day, it boils down to the paying capacity of the patient. Next slide, please. So this is the other study what I was talking to you about, which was conducted by the Psoriatic Arthritis Special Interest Group, also known as PASIC, in which this was mostly a questionnaire-based study in which they studied 262 patients with psoriasis and psoriatic arthritis. What I wanted to point out from this table is this essentially is a comparison of all the other cohorts along with this one. But what I wanted to bring to your attention is the red marked area, which shows that the patients taking conventional DMARDs was 75%. which is indeed quite a high number. And biologic therapy was there only for about 10%. And if you look at the satisfaction with current treatment, it clearly shows that 60% had overall satisfaction with whatever disease, whatever drugs they were on, and 88.5% with biologic DMARDs. And there was partial improvement in a third of them. So it essentially means that, yes, people do get, good response with biologics, but about 2/3 of them are still overall happy with whatever treatment they were on, which essentially goes back to the previous step in which most 75% of them are still on conventional DMARDs. Next slide, please. So let's switch to this interesting topic of axial spondyloarthritis, which is actually the hot topic at the moment. So there is no definition as of today which can clearly mention or to understand what axial psoriatic arthritis is. So oftentimes we fall back on the indices, both clinical as well as patient reported outcomes. We go by what we have for spondyloarthritis. And this led to the whole point of understanding what axial psoriatic arthritis is. And this is, in fact, we're still yet to see the results in full, is a combined project by Axis Study, which was a combined project by GRAPA as well as ACES. And we do have some preliminary results, which I'll be sharing to you in a bit. So this current slide talks about the definition of axial psoriatic arthritis and the prevalence, which spans across from 5% to 70%, is such a wide prevalence. The reason being we don't have a definition as such. And this study was actually done in Toronto, where they looked at patients who were enrolled in the spondyloarthritis clinic, which is mostly axial SPA, and psoriatic arthritis clinic, which is psoriatic patients, psoriatic disease patients with back pain. And this was a perfect model to compare both, because this was not driven by any physician, because they were referred by the family physicians, but they looked at the models by which how patient landed up in each of these clinics. And what they found out was the age of AxSpA patients were pretty younger, which is about 15 years, and AxPSA appeared pretty late. And one of the major things, I'll come to that in a bit when we deal with imaging, is when you talk about older patients, you're dealing with some inflammatory lesions as well as degenerative lesions. So it's all the more difficult to kind of tease out what is what. So that leads on to the conundrum. The presentation to clinic was earlier, of course, in AxSpA patients and quite late for PSA patients. HLA-B27 was higher among AxSpA patients. Axial disease activity was certainly worse as compared to PSA patients who had worse peripheral disease. Radiographs showed classical syndesmophytes, and we know that PSA patients can have, of course, non-marginal syndesmophytes. And of course, we'll come to the MRI findings in a bit. Next slide, please. So this is actually back to the question of, can we really fall back on this history of back pain in a patient with psoriasis or psoriatic disease? This was, again, study done from the International Psoriasis and Arthritis Research Team, which is called IPART, based in Toronto. They looked at patients who had back pain, who had, of course, psoriasis and psoriatic arthritis, also had back pain, and they got 93 patients with psoriatic arthritis and psoriasis with suspected spondylitis. And all of them had undergone MRI scans of the sacroiliac joints and whole spine. And what we see here is there was actually a poor agreement between the MRI findings and the ACES classification criteria for axial spondyloarthritis. Now, if you look at here, only 12.9% of patients who had sacroiliitis by MRI, out of which 57%, although 57% had inflammatory back pain, only about 13% had spondyloarthritis by MRI. And again, male sex was associated with MRI abnormalities, and there was a high discrepancy between symptoms and MRI findings. And here again, we see the difference in the inflammatory back pain versus the MRI findings. So we know that just going by the findings, we can't really differentiate axial PSA from AxSpA or somebody who has a spine involvement versus somebody who does not have spine involvement in psoriatic arthritis patients. Next slide, please. So this led to, this is actually a study done way back in 2015 in Denmark when they looked at whole body MRI, which is coming up in a big way in psoriatic disease. They compared patients with spondyloarthritis with patients who had axial PSA. Next slide. Can you move, please? So this was a comparison between those patients who had psoriatic arthritis and patients who had spondyloarthritis. Now, and this is actually the bar at the bottom is the intensity of frequency of lesions, which starts from white all the way to black with the frequency or percentage of lesions in these patients. Now, if you look at the sacroiliac joints, we see that in spondyloarthritis patients, it was far more than those in the patients with psoriatic arthritis. However, if you go to the spine, we see that it was, especially the cervical spine, patients with psoriatic arthritis had worse disease as compared to, or worse lesions as compared to patients with with spondyloarthritis. So if you look at just the SI joint, you know that AxSpA is quite worse. The lesions are quite intense and quite frequent as compared to those with patients with psoriatic arthritis. However, if you look at the spine, we see at least in the cervical spine and more so in the posterior side, posterior elements of the spine, of the cervical spine, we see that patients with psoriatic arthritis had more lesions as compared to patients with spondyloarthritis. Next slide, please. So this was the distribution of lesions in the spine, what I was talking to you about. So this, if you look at the psoriatic posterior part, PSA patients had more lesions or more frequent lesions as compared to spondyloarthritis. And all the others, there was not much of a difference in the spine at least, but we know today that most of the scoring systems which are used to score spine MRIs used to just focus on the vertebral body, but we know that after a lot of studies, we know that it's a posterior element which is more important for spondyloarthritis, including axial PSA. So we have the CAN-DEN, which is the Canada-Denmark scoring system, which deals with all the aspects of the vertebrae, including the body of the vertebra as well as the posterior aspect, both for inflammation as well as structural lesions. However, if you look at the SI joint, we see that, like what I mentioned, spondyloarthritis patients had more number of lesions as opposed to psoriatic arthritis patients. Next slide, please. So this leads to the study what I was mentioning about, which is called the AXIS study. This was presented at the just concluded ACR, which the study had about 50 centers right across the globe. And we looked at what could be the definition or the final endpoint of this would be, in fact, to work on a classification criteria for axial psoriatic arthritis. So all patients who had less than 3 years of disease, psoriatic disease, who were not on any targeted therapy, underwent a clinical examination as well as quite an extensive MRI study along with radiographs. And this was initially studied by the local investigator, and all the images were sent to the central investigator, central readers. And then with the clinical data, the local investigator had a chance to just go through both their scores as well as the MRI reads from the central readers and change their classification of patients who were classified or were not classified as axial psoriatic arthritis. So if If you look at this graph, it just shows the one on the left is by the local readers, local investigator, which is the first assessment in which there was 37% of patients who had axial involvement. Now, after the readers, central readers read through all the MRI and radiographs, there was a fair bit of difference between the first assessment and those of the central readers. However, when it came to combining what was the central readers' lesions, which were read by the central readers, and the local reader, it went up to, again, 27% from 23. So essentially, axial involvement, both in clinical as well as imaging, was observed in close to about a fourth of patients. Now, what was interesting was inflammatory back pain, HLA-B27 positive patients, higher CRP levels, presence of active inflammatory and structural lesions in SIJ as well as spine were associated with axial PSA. Like what I mentioned, the work is on for a classification criteria. We hope to come up with something the next year or so. Next slide, please. So back to this whole aspect of what is psoriatic disease. Now, generally, we mention a psoriatic disease because we're not just talking about the joints like what I mentioned first. We generally have these 6 clinical domains. However, what is more important is this nebulous concept of comorbidities and pain. So this has been a major kind of a reformation in this field over the past couple of decades. And we know that when you talk about the psoriatic disease, we have a whole lot of metabolic syndrome. You, of course, have extra-articular manifestations and extra MSK manifestations, which include uveitis, inflammatory bowel disease, and osteoporosis. Depression and anxiety is a big chunk of comorbidity, which actually hasn't been looked into in detail so far. And we do have central sensitization, osteoplastic pain, fatigue, fibromyalgia, and chronic widespread pain, which just adds to the whole conundrum. So we know that when you talk about the disease, the psoriatic disease, this is kind of a snapshot what we're looking at in a particular patient. And so it just talks about the burden of the disease in total. Next slide, please. I just wanted to bring this particular paper, which was actually quite interesting, which was published way back in 2011, which was actually a psoriasis patient. They did a PET, FDG PET in about 6 patients. This picture from one of them. This was a 40-odd-year-old gentleman who had psoriasis, and they did FDG PET for these patients. Here we see the figure over here. We can see the psoriasis lesions or the inflammation in the psoriasis lesion. But what is more interesting was they compared that with a control patient who did not have psoriasis, and we can see the extent of inflammation which was picked up. So right from the descending thoracic aorta, descending aorta, you have the liver, which has a fair amount of pickup. Here you have the arthritis, you have the vessel, which has picked up inflammation. You have the enthesitis, which is a greater trochanter enthesitis. And of course, your skin lesions also have been picked up. So there's no such inflammation in a person who is a control, which is normal. So this was actually a big learning exercise, which showed that inflammation, although whatever we see as a skin disease or skin psoriasis, many times patients feel that, it's just a skin disease, it's not much of a problem. If you scratch the surface, we see that it's a huge inflammation ongoing underneath. So no matter what the amount of psoriasis or arthritis it is, model of the story is it has to be controlled as much as we can. Slide, please. So this is a whole list of comorbidities. As we talk over here, I think I'll have to acknowledge the young Europeans over here, which have come up with a fantastic deck of slides which are free to be used. Anybody can download it and can be used, for any of your presentations. And these are fantastic set of slides. In fact, we do have translations in many of the languages as well. So back to the slides, the comorbidities and PSA, we see that the top of the whole thing is we can club together as a CVD-related or a metabolic syndrome diseases, which occupy the top of this the graph on the left. And as we go down, we see a whole spectrum of diseases involving a multi organ disease, so to say, including the bones, osteoporosis, cancers, you have COPD, but the major hit is because of the inflammation. We do have a whole lot of cardiovascular diseases ongoing. Next slide, please. So this was actually a comparison of psoriasis and psoriatic arthritis, which showed that psoriatic arthritis patients do have higher prevalence of METS, metabolic syndrome, and these are each of the components of the metabolic syndrome. Here again, we see that patients with psoriatic arthritis have a higher burden of having at least one cardiovascular risk factors. And mind you, most of these patients do have multiple comorbidities. It's not just one of them which adds to the whole picture of the disease itself. Next slide, please. And we have studies which have shown that one RCT over here, which, as mentioned, shows the diet-induced weight loss has been shown to bring down the disease activity. We do have studies which also show that if patients reduce weight, the DMARDs act better and they reach MDA faster as opposed to somebody who does not lose weight. Next slide, please. So if you look at the cardiovascular morbidity in psoriatic arthritis, we see that patients with PSA have a 43% higher risk of developing a cardiovascular morbidity. Next slide, please. Next, please. And here again, even in myocardial infarction, we see that there is a 68% higher chance as opposed to general population. So stroke, again, is higher in patients with psoriatic arthritis. There is significantly increase of a relative risk of 1.33 as opposed to patients who did not have psoriatic arthritis. Next slide, please. And of course, VTE in the background of JAK inhibitors, which was again higher for psoriatic arthritis and as compared to psoriasis patients. Next slide, please. So coming to an important aspect of the liver disease, this has been one of my areas of interest, although it's so difficult to get data out of it. This is something which has come up, and even over the past few years, if you look at it, the nomenclature of NAFLD has been changed to MASH, which is metabolic dysfunction-associated steatotic liver disease, MASLD. And this chart shows this first plot talks about the systematic literature review in which we see that the odds of patients with PSA developing liver disease is higher than those who did not, or just with psoriasis. Next slide, please. This was actually a study, and apologize for the change in text. This was a study which was just presented in the IRA meeting, in which we studied about 142 patients from our center, next slide please, for the liver abnormalities. And out of the 142 patients, there were 72 who had liver abnormalities, and we compared them with those who did not have, and we saw that out of 72, 51 of them had transaminitis, which is by far the chunk of it. But what is more interesting was treatment changes where, because of the liver problems, treatment changes came up in a third of patients, which was kind of important message throughout this study. Next slide, please. Coming to depression, this is actually an interesting topic which has not been touched upon so much. There are a lot of studies coming up of late which has shown that compared to patients with psoriasis or compared to patients with the normal population, patients with psoriatic arthritis seem to be having a higher risk of developing depression and suicidal burden, and that is something which has to be looked into in quite detail. Next slide, please. So this is actually, if you look at depression, we can kind of deep phenotype it further down, and we do have questionnaires for each of these things to screen. The patients can have an overall depression. They can have certain types or subtypes in the depression conundrum, which could be a cognitive disorder, it could be anhedonia, can be alexithymia, and again, one way of, thanks to the functional MRI aspect, which has kind of brought out the differences between these phenotypes in depression. And if you look at the one of the treatments actually for MDD is in fact TNF inhibitors. So we know that there are common pathways for MDD, depression, major depressive disorder, and all these immune-mediated inflammatory diseases, which is TNFI. Next slide, please. So this was actually a study which we did in Toronto when we looked at 1,270 patients, and patients were divided into depression and not depression based on the MCS and MHS of SF36. By definition, it was MCS of less than 40 and MHS of less than 56, and we divided the patients based on the treatments they were on. So category into three exclusive baskets. The category one was patients who were just on NSAIDs or no treatment. Patients with conventional DMARDs were placed in category 2, and category 3 were patients who had targeted treatment. And the primary outcome was resolution of these definition-based depression within 1 year. And these are the univariable and multivariable models of the study, where we find that there was no difference between any of these categories when we compared these categories across these categories. However, when we compared category 2 and category 3, which essentially means conventional DMARDs and targeted therapy, the patients who were on targeted therapy had better odds of attaining a resolution by this definition at the end of 1 year, 1.71 odds of attaining remission or resolution at the end of 1 year. So we know that targeted therapies are actually helpful in patients dealing with depression in the psoriatic arthritis cohort. Next slide, please. Now, why do we have these comorbidities laid out so elegantly? The major reason is it actually drives the treatment plans. When we sit with the patient and discuss these therapeutic challenges, we see that a lot of drugs cannot be used in certain situations, and that is actually how we prioritize treatment aspect based on the comorbidities. And we have all these comorbidities on the left, and we see that, of course, NSAIDs, we do have issues with CVD, methotrexate, we do have issues with liver, and of course, infections, which are quite high prevalence in this part of the world. TNFIs are fairly straightforward. It can be used for depression. That is one of the best things which TNFIs have in common, as well as IL-17 inhibitor. Although initially there were some issues with brodalumab, however, it got cleared, although we haven't got a FDA approval as of today. So this chart gives a clear indication of how to use these biologic or targeted therapies and conventional DMARDs in patients with comorbidities, including infection, as well as the ones which I just alluded to. Next slide, please. So that brings into this whole concept of pain, which actually is an elephant in the room. And this, we know that pain is seen in more than 50% of patients, in spite of conventional as well as biologic DMARDs in most of the trials, as well as in real life setting data. And that's why somehow I feel that there is a huge gap between the physician assessment and what the patient's perspective is about the disease. Because most of the time physicians are kind of tuned to getting inflammation and what is the burden of inflammation, what is the pain because of inflammation. However, patient acceptable symptom state is something which encompasses everything what the patient thinks about the disease into one question, which is a dichotomous answer. Either it's a yes or a no, just by asking the patient, if we were to go at this present state, or rather last 48 hours, whatever you've gone through, if you were to go in the same state of disease for the next few months, would you be happy with it? And that would give a complete answer to the problem, rather than from the physician's eye, which we gently tune to pick up inflammation and the other aspect of clinical domains of psoriatic disease. Next slide, please. And we also know that all pain is not inflammatory, and that's something like a new concept, are kind of an evolving. We haven't really reached there. A lot of these gaps up there still. We know that nociceptive pain is actually what is driven by inflammation, what we generally have in terms of the disease as such. Most of the inflammation is driven by nociceptive. Neuropathic pain can be because of the nerve damage, where you have, it could be like a diabetic neuropathy where the nerve itself is damaged. And nociplastic pain, which is often thought of as a branch of a chronic widespread pain, but these are totally different terms. Nociplastic pain is something which has come off late, and oftentimes we see that there is a combination of all these three entities in a patient with psoriatic arthritis. And unless it's so difficult to tease out these pain patterns if you were to take a patient as a whole. Now, this the figure on the right side depicts the definition or how to approach a patient with nociplastic pain. So essentially, the pain has to be for more than 3 months. It has to have a regional distribution, whereas in patients with chronic widespread pain, it can be a widespread pain. So that is one of the major differences between nociplastic and CWS, or chronic widespread pain. And then if it is a yes, then it go down to evoked hypersensitivity phenomenon, yes or no. You have pain hypersensitivity in the region of pain, yes. And if you have at least one comorbidity, most likely a probable nociplastic pain. If not, it's a possible nociplastic pain. So essentially what I wanted to bring home through this slide was most of the times we can't really tease out the differences in these. And what we need to understand is close to about 60% of patients do have issues with a combination of all these three pain, or at least a combination of two of these. And that adds to the diagnostic as well as treatment aspects. And that's where this role of ultrasound has come up in a big way over the past few years. Central sensitization is quite prevalent in diseases, especially with PSA, and it's seen in close to about 50% of patients, and it is important detrimental determinant of functional disability. And there was a study which showed that central sensitivity was independently associated with functional disability in PSA. However, DAPSA was not. So that is the figure on the right again talks about the root or how it controls the patient's life. Next slide, please. And fatigue, to add to the matter, is again in the middle of, if you look at the central, the middle circle, you have fatigue and pain in that, which is worst symptom after pain. This is actually a study done in the Landbio patients in which they looked at, they categorized patients with fatigue score, which is less than 57, which is none to mild, and VAS score of more than 57. And they could see that women with higher DAS28 CRP, higher VAS pain and VAS global health, and PDQ square and higher HAC was associated with a VAS of more than 57. Next slide, please. So coming to the concept of difficult to treat PSA, I think Philip just mentioned about that in detail. We do have, next slide, please. So I'll just skip this and go into the complex to manage pain aspect, which this is actually a study done by Grappa. Now, as Phil mentioned, we do have a Grappa study trying to understand and to come up with the definition of D2T as well as C2M, complex to manage. So if you look at this survey, which is sent across experts in Grappa, we see on the left side the factors contributing to C2M, which essentially leads to a whole lot of things outside the joint. If you look at that, if you see the first one, the number of correspondents on the left side, chronic pain was a major concern for most of them. High impact of disease activity, of course, yes. Persistent fatigue, side effects of medications, loss of effect of multiple medications. So these are the factors which contributed to C2M, and the contributors to difficult to treat were mostly related to the drug and the disease, inflammatory component of the disease, along with chronic pain. Next slide, please. And the aspects contributing to the same were pretty much disease-related. On the left side, what we have difficult to treat, which is enthesitis, arthritis, dactylitis, nail, skin. And on the left, if you look at it, it goes a wide spectrum, which includes depression, chronic pain, fatigue, other comorbidities which form the chunk of it. So there has to be a distinction between these two, and we can't really club them, although we know that there are overlaps between these two. And GRAPPA, through their survey, was very clear that we need to have definitions for these two separately, one for D2T and one for C2M. So coming to the key takeaways, unique stumbling blocks are quite prevalent in India, and we have mechanisms to fight that. However, we need to understand that most of them are still happy with conventional DMARDs. Next slide. AXE-PSA is seen in about a fourth of patients. MRI is helpful, and especially when we talk about the posterior elements of the spine. And like what I mentioned, this recent study from Xenophon's group has clearly mentioned how we do have a fair bit of degenerative changes in the spine, and that adds to the difficulty in reading these images as well. Comorbidities should be carefully evaluated. They do have treatment implications. Careful assessment of pain is really a must to choose the treatment rightly. And of course, we need to distinguish what is D2T, which is difficult to treat, from complex to manage patients. Thank you very much, and happy to take any questions.
Thank you, Professor Mathew. We have quite a few questions. We'll take a few of them in the next 7 to 8 minutes. So the first question we have here is for Professor Mease. What's your first choice targeted therapy? So just to broaden that question, where no one domain of PSA is predominant, what's your go-to targeted therapy? And the second part I'd like to add to it, when you're choosing TNF inhibitors, you've decided that you're going ahead with a TNF inhibitor. Is there anything to choose between which do you prefer and why?
Thank you. So the first comment to make is that we are somewhat guided by insurance dictates, as we call it, where we will be pushed into use of a slightly less expensive medication than another. So I would say that, therefore, one of our often first choices that's partially guided by these dictates is adalimumab biosimilar, because it's less expensive than others. If we can, we just simply ask for adalimumab, and then our prior authorization nurse works with the insurance company, and we either get the originator adalimumab or the biosimilar adalimumab. That's probably our most common first out of the chute. I will acknowledge that some patients are very, very, very safety conscious, and we may end up using an IL-17 inhibitor if allowed, or an IL-23 inhibitor if allowed, in that first position, partly because of a slightly better safety profile, including slightly less serious infection. In terms of choice between TNFs, I will acknowledge that there is, although equal efficacy for musculoskeletal domains with etanercept as compared to the monoclonal antibody constructs, the monoclonal antibody constructs are far more far-reaching and will more beneficially affect the gut or skin in psoriasis or IBD or psoriasis and uveitis. And so we may choose a monoclonal construct like adalimumab or certolizumab or Simponi or infliximab for that reason.
Thank you, Professor Mease. So, Professor Mathew, the next question I'd like to put to you, it's digressing a bit from PSA, but since we have talked about axial disease, the question, although is patient-specific, but I would want you to address the larger issue. So the question is that there is a 32-year-old male who has clinically inflammatory back pain for the last 4 or 5 years. There is history of suggestive of dactylitis. Sister has a history of Crohn's. The nephew has axial spondyloarthritis. The patient has reduced lumbar flexion. Faber's is positive. HLA-B27 is negative. MRI of the cervical and lumbar spine just shows degenerative changes, nothing else. Pelvis MRI is normal. CRP is significantly raised. So we often come across such scenarios. So would you put this patient as in how confident I would want to ask you, would you be putting it as axial spondyloarthritis or otherwise?
First of all, that's a tricky question. And if you were to ask me, I'll just go back to the MRI and read again and see if you can get any, because clinically it's pretty straightforward. You said patient has inflammatory back pain, although we know that inflammatory back pain is not a sine qua non for axial spondyloarthritis. However, and the patient has dactylitis. Again, it could be, if I were to stretch it far, it could be dactylitis can be there for tuberculosis. You can have spine involvement in tuberculosis. So it's and with this background history, it's pretty much straightforward that it could well be. So I'll certainly go back and read the MRI and try to make sure that what I'm dealing with is axial spondyloarthritis. If not, certainly I'll have to look for infections and I won't be in a hurry to start any treatment for that matter, because we know how prevalent tuberculosis is in this part of the world. And we, in fact, see a lot of patients with treatment-resistant tuberculosis. So these things I'll have to rule out. But if having ruled out everything, if I'm convinced, then I would certainly go for the cheapest available, as well as spine, IBD, all these things put together. I will certainly go for TNF inhibitors. And since we have adalimumab, which is quite prevalent in use, I would certainly fall back on that. But I'll be certain to rule out tuberculosis before I start on that.
Thank you. So, Professor Mease, another question is, how far apart can you space the 2 doses of adalimumab in a patient? And the second part of the question that has come is, if the patient is on minimal disease activity or the disease is inactive for over an year, can you think of taking the patient completely off medications?
Right. So in terms of the first question, I'm quite comfortable with patients spacing out adalimumab to once every 4 weeks. And we do have some patients who travel, especially from Seattle, where they work in the tech industry and travel to India. And so they prefer not to have to figure out refrigeration. So they will either typically take 2 injections of adalimumab and separate them by a month because there's a prolonged half-life phenomenon that allows that to be the case. So that's the first comment. Second was the ability to stop a treatment if the patient is in prolonged remission. We certainly see this, and we certainly see patients voting with their feet, so to speak, where they'll come back to us after 6 months and say, well, gee, what really has happened here is I've been doing so well that I've tried without my medication. Typically, what we see is that in most patients, the disease ends up coming back. It may take 4 months, it may take 6 months, but eventually there is recurrence of disease. So that's the great majority of patients. We don't yet have for example, in the cell therapy field, we're getting some very, multi-year remission with use of CAR T cell therapy. We're not there yet with psoriatic arthritis. There's some possibilities in the future, but not now. So we tend to try to keep the drugs going. And one small point to make is that with the old experience with infliximab, when it was used episodically in treating inflammatory bowel disease, study in the Netherlands, it showed if you had a prolonged absence from the drug while the patient was not having active disease and then returned to it, there were more infusion reactions and there was more anti-drug antibody development, and which would then inhibit the drug from being effective. And so I'm a little bit cautious about pausing too long for that reason as well.
Well taken. So for the paucity of time, one very last quick question to you, Professor Mathew. What drugs do you find are effective in the management of nociplastic pain?
Great question. I think who should be the one who should. So we still, honestly, we still haven't really got to how to measure. If you were to put some numbers, like, if I were to go back to the question, the previous question, we know that even for drug spacing, it's not for the spacing as in terms of time duration. We have a study which showed that MRI can be used for drug spacing, which, in fact, there was a study from Denmark in which they cut down the dose by 2/3 after 6 months. Based on MRI lesion, they could predict which of them will go. So back to this question, we still don't have anything objectively to measure nociplastic pain, but still we do have evidence, some evidence which show that, of course, we know that 60% of patients on TNFi still do have pain. And when I say pain, it's just not nociplastic, it's a mixture of all these three. So if you take off one, which could be part of the disease, I think, and most of the, in fact, if you look at the JAK inhibitors, they show quite an early response to pain suppression as opposed to the other biologics. And we certainly have data on bimekizumab and a few others which show that quite early in the course of the disease, there is a drop in the pain levels. Now, when you talk of pain, again, there are two types. One is the indirect effect and the direct effect. Now, what we're talking about, the drugs causing, is the indirect effect. And the direct effect is because of all the other pain. So it all depends on how these things come together. But given the Indian choice, I think I'll fall back on TNFi again, because that seems to be the cheapest, the easiest available. However, I still consider JAK inhibitors for pain relief if that is a major concern. And probably I won't be in a hurry to switch just based on the pain part is alone, and probably I'll have to mix things together.
So I'll jump and just add a sentence, which is that we sometimes at this juncture will not necessarily switch biologics if we think nociplastic pain is a predominant issue, but may use an SNRI inhibitor, so that, for example, a patient who is using duloxetine would be an example, and then some patients with pregabalin or gabapentin will get some benefit. We try very hard to steer away from use of any opioid-based analgesics.
Thank you. So I wish we had the time for all the questions, but for the paucity of time, now I hand over to Dr. Yogesh Sharma.
Thank you, Dr. Mohit, for moderating the entire event. And on behalf of Abbott and the IRA eConnect, I would like to thank the esteemed and distinguished faculty for their insightful presentations and very interactive discussion that we just had. So I would like to extend my thank you to all the distinguished faculty as well as Dr. Mohit for facilitating the complete show. Next, I would like to definitely thank all the delegates, because it's a Friday, it's a busy OPD day, and we have close to 400 doctors who have logged in for this current program, and they have stick to it entirely, and they have, we have very positive response for this particular program, and I'm thankful to delegates for showing off, this presence for this particular event. I would also like to thank the background technical team for helping us out with the technicalities. And with this, I would just like to ensure that we will be continuing this series of interactive speaker programs, getting the experts from the globally as well as the Indian experts in the next year also. And we would have differentiated topics for the Indian rheumatologists. With this, I would like to thank the speakers as well as the delegates, and have a great evening forward, and a great day to Dr. Mease as well. Thank you so much, sir.
Thank you.
Thank you. Bye. Bye, Dr. Ashish.
Thanks, Phil.
Bye, Dr.
See you next
Mohit.
week.
Bye.
Thank you.